Hi, everyone, and welcome to the Rare T-cell lymphoma breakout session. I am Sarah Quinlan from the LRF, and we are thrilled to have Dr. Stephen Horwitz presenting on this topic today. Dr. Horwitz is a medical oncologist with a clinical expertise in T-cell lymphoma at Memorial Sloan Kettering Cancer Center. He is also a member of LRF's prestigious scientific advisory board. Thank you so much for presenting today. And after the presentation, we'll definitely have time for questions. And I'll hand the program over to you.
Great. Thank you. Thanks for having me. I just see some people are just joining, so I'll start off slow. And then I will share my screen. Let's see how this works. Where did that go? I'm not seeing the screen I want to share. Hold on one sec. Or maybe it's just... Oh, it worked a second ago. I don't want that. Give me one sec. Let's try this. Share screen. There we go. Okay, and I'll put that on. Slide presentation. Okay. So it's nice to be with you all, albeit virtually. And what I was going to talk about today, what I was asked to talk about is it's sort of a challenging subject to do as an overview, but really talking about some of the rare T-cell lymphomas. So, you know, we have uncommon diseases, we have rare diseases, and I think some of these T-cell lymphomas in general are an uncommon or rare disease, and then some of these specific subtypes are really what we sometimes think of as ultra rare or super rare. And they're sort of a heterogeneous group. So I'll kind of make that point, and then I will go through each subtype, talk a little bit about the disease, how we think about it, how we might treat it, and then just try to leave plenty of time for individual questions if they're there. I'll try to monitor the QA in the chat if people have questions during the talk, and if they're sort of within the topic of what I'm covering, you know, maybe we'll answer them in real time, and that's fine with me for people to interrupt. I don't think I can see people raising their hands, and then we'll have plenty of time at the end. Hold on one second. I'm just on call. Sorry, I literally just got paged. Okay, real life stuff. Okay, so I'm going to talk about rare T-cell lymphomas. I'm going to really just kind of walk through some of these subtypes: adult T-cell leukemia lymphoma, enteropathy, associated T-cell lymphomas, hepatosplenic gamma delta T-cell lymphoma, nasal NK, subcutaneous panniculitis, but we can sort of talk about whatever people want. So these are disclosures. We think a lot about disclosures. So I do consult for a number of companies that are interested in developing or finding better treatments for people with T-cell lymphoma, shown here. And then we do clinical trials as part of my job. So we do have research support to my institution from a number of companies that are, again, pretty much all looking at better treatments for people with T-cell lymphoma. Okay, so T-cell lymphomas are heterogeneous. By heterogeneous, we mean they're variable. There's a bunch of different subtypes. So in the latest classification system by something called the WHO, I think if I count again, there's about 29 different subtypes of T-cell lymphoma. So already a rare disease. And then when we think about as a patient or someone with a family member with an individual type of T-cell lymphoma, it really gets down to sort of the nitty-gritty of what is the exact subtype you have. So this is just a way of thinking about them. As probably most people on this call know, T-cell lymphomas are cancers of a kind of white blood cell called a lymphocyte, and most lymphomas start in lymph nodes. T-cell lymphomas, a little more often than B-cell lymphomas, tend to be what we call extranodal, or primarily or mostly outside of lymph nodes. And one of the ways of thinking about T-cell lymphomas, just to get your head around the different groups, if you're looking at the spectrum, is where they present in the body. So there's a group that present primarily in the blood, and we call those leukemic. Cutaneous T-cell lymphomas are a group that present primarily in the skin. I know there's a separate breakout session on this. Nodal T cell lymphomas present primarily in lymph nodes, and then there's a group that are otherwise extranodal. And some of these we'll talk about. NKT cell lymphoma tend to present inside the nasopharynx, in the mucosa in there, and neuropathy in the gastrointestinal tract. We'll talk about subcutaneous panniculitis like T cell lymphoma, which presents in the deep tissue below the skin. And I tried to put in purple, though I think I misrepresented some of the ones that we're going to talk about. So these are the list of them, and this is a pie graph from a retrospective look done at sort of across the world at the relative incidence or the frequency of different types of T cell lymphoma. We think in the United States there's about 7,000 or 10,000 people a year get T cell lymphoma. So if we think about 1% of all T cell lymphomas in the United States, we're talking about 70 to 100 people a year. And if you look at some of these subtypes, they're really in sort of that 1 or 2%, 5%, 10%, but really on the order of maybe less than 100 to up to 1,000 people a year. So these are by definition what we would call these ultra rare diseases. And it does make it harder to get sort of good information about those. Sorry, I'm just trying to monitor the Q&A in case anyone has a question. So I think some of them, as I tried to show, are very rare. I think what does that mean for people who have them, or for those of us who take care of people who have them? It means that there's often limited data, limited compared to other types of lymphoma or other types of cancer, where we more often have large data sets, deep experiences, maybe large prospective studies that help us understand some of the ways we treat them. I think one of the things I think about is that you really need to make sure you have the diagnosis right. So expert pathology review, given how rare these are, an average surgical pathologist may see 0 to 2 cases a year. So it's something that it's hard for anyone to be totally up to speed on. So for these very rare diseases, we try to recommend seeing at a center or by a pathologist who has expertise and experience. It doesn't have to be a big cancer center, but it's often a big cancer center. And that you really want to make sure you have the right diagnosis. And through the talk, I'll talk a little bit about some of the ways other diseases or illnesses might mimic or overlap with these. Another thing I think about these diseases, and particularly these rare diseases, which kind of go true for T cell lymphomas in general, is the disease definitions are really what we call clinical pathologic entities, meaning a pathologist looking at a microscope without any other information, it can be very challenging to assign or understand the right diagnosis, because part of the diagnosis of these diseases is what's going on clinically, or we mean in the person who has it. Is it in their skin? Is it in their nasopharynx? Is it in a lymph node? Are they sick? Are they not sick? Has this grown in a month? Has it been there for 2 years? So in that sense, they can be challenging diagnoses to understand clearly, and we have a lot of communication between the doctors seeing the patients and the pathologists who are looking at the biopsy material. Kind of as I mentioned, there's few prospective trials. So while some of these patients are included on larger trials, for these rare diseases, there's not often large trials of these diseases only. And therefore, our treatment approaches are often partly based on experience, by extrapolation from similar diseases, or maybe from larger studies that included groups of diseases, or series in the literature where people get together and they write about their experience. So in that sense, it's just harder to get sort of very concrete information that leads to decision making. So one of the ways I think conceptually I think about this, and sometimes I show this this slide when I'm talking to doctors about this, is a lot of people think about, for an aggressive lymphoma, that we have CHOP-based chemotherapy. So CHOP is a chemotherapy regimen. For aggressive B-cell lymphomas, when we add rituximab, most people are cured with a finite course of therapy, usually 4 to 6 months of treatment. And most of our treatments for aggressive T-cell lymphomas, and we'll talk about which ones of these diseases behave aggressively and what that means, but for aggressive T-cell lymphomas, we think about treating with curative intent. That means we're trying to get rid of it forever, and that means we're primarily giving combination chemotherapy. And there's a group of T-cell lymphomas in the middle where CHOP-based chemotherapy or modifications or intensifications of that regimen do reliably cure people. And we think in those people it's reasonable. And then there's a whole group of diseases over here on the left where if you took that same approach, you gave CHOP or something like CHOP, chemotherapy for some cycles, either you would never cure them because those are not the right treatments, or those diseases are chronic or indolent and don't need aggressive therapy, and it's really not the right treatment. And then there's a group of diseases, which we'll talk about a little bit, where there's such limited data, it's really hard to say one way or another that there's a right approach. But when we see these people, often we talk amongst ourselves and sort of come up with what makes most sense for that patient. So I'm going to start with HTLV1 associated lymphomas, or what's called ATLL. So the name of the disease is adult T-cell leukemia lymphoma. I'll explain what that means. And these are lymphomas that are associated and really caused by infection of the HTLV1 virus, which is a retrovirus that lives in some people, often for their lives. So when we think about HTLV1, so that's a virus, it really probably originated in sub-Saharan Africa and probably was spread as people moved throughout the world. If you sort of look at the orange areas, with where the incidence is sort of 1 to 5%, South America, the Caribbean, those people were moved without their consent. Those are basically slave trade routes, and you can see how the routes sort of moved from Africa to South America to North America. And there are areas like in Haiti where maybe 25 or more % of the population carries the HTLV1 virus. There's another group in the northern and southern islands of Japan, which may be separate in terms of its derivation, or maybe those were routes. And then there's these clusters, some in the Middle East, some in New Guinea. In places like the United States or London or parts of France, those are usually people who later on immigrated either from the Caribbean or from Africa. Most people who have this virus get it from their mother when they're born or through breastfeeding. So there can be vertical transmission, or there can be transmission through breastfeeding. And people who have this virus most often live a normal life. About 5% of people will get lymphoma or leukemia, but about 95% of people who have this virus, they'll be fine their whole life. There is a possibility of also sexual transmission, and we think that's probably less frequent in terms of these endemic populations, but it may be part of it. A smaller number of people with this virus will get a neurologic condition, but the thing we mostly focus on is this lymphoma. So in New York, for instance, where the US is not a highly endemic area, there are many people from the Caribbean who live in New York and the tri-state area. So this is a population that does live where we are, where parts of the United States, this virus would be incredibly infrequent. Sorry, there's going to be just a little background noise. Some things about HTLV1, I sort of mentioned that lymphoma develops in a small percentage of carriers, maybe 2 to 4%, maybe 5%. But again, most people who have this virus are healthy their whole life. We think what happens is people who are asymptomatic carriers, if you look down here, just have the virus. It tends to live in your T cells, probably more often in your CD4 positive T cells. And a lot of the time it might sort of mind its own business. But over the course of someone's life in multiple cell divisions, this virus can incorporate into the DNA in different places. That can, in effect, either do nothing, or it can turn some genes on. It can make those cells grow more frequently. And people can kind of go through this intermediate phase. I'll talk a little bit more about this in a few slides, where some of those cells are not cancerous, but they're starting to behave like cancer. They may be growing more frequently, dividing more frequently, maybe persisting longer. And then if that progresses, often what people will get is a subpopulation of these cells that may grow very slowly. There's some indolent or sort of chronic forms of this. When we say indolent in lymphoma, we mean that those lymphomas grow over years, not months. And they may persist. Some of those people don't need treatment. And then in some people, the disease may sort of evolve or progress to what we call the aggressive subtypes. When we say aggressive in lymphoma, we usually mean that the lymphomas are growing in months or weeks, and those are the diseases that can more quickly become life-threatening or dangerous. And those forms we call acute or lymphoma for people who develop large lymph nodes, acute for people who develop high numbers of cells circulating in the blood, or a leukemic presentation. And when that develops, people are often quite sick. So again, we classify ATLL into 4 subtypes. The indolent or slow-growing forms are chronic or smoldering, and the more aggressive or fast-growing forms we call acute or lymphoma. Therapy is really based on subtype and sort of based on the available therapies we have. So sometimes for the very slow growing forms, people will be observed only. This may show up as a few cells in the blood. It may show up as a mild skin rash. Often because there's a potential that these will get worse, we will try to treat what we think of as milder sort of non-chemotherapeutic medicines. Interferon, which is an immune stimulant, is sometimes used, sometimes in conjunction with antiviral medicines. I'd point out that antiviral medicines by themselves don't work for this disease like they do for other viruses. Lenalidomide, which is an immunomodulatory agent or drug that's used for some low-grade lymphomas or mantle cells, sometimes used for multiple myeloma, has some activity in this. And there's a monoclonal antibody that targets a protein on many of these cells called mogamulizumab, and that's sometimes used. The treatment for these early or slower growing forms of the disease tend to be chronic or maintenance, meaning we would try to find a mild treatment to keep someone well, maintain the disease under control without putting them at high risk or significant risk from the treatment. And if you find those treatments and they work well, people can have their disease controlled often for quite a long time. There are also some investigational treatments, and I'll mention some of those approaches. I think when we see someone who has either more aggressive disease, acute or lymphoma type, or has one of the chronic diseases that's progressing, so it looks like they're on the way to that, we often think about moving up to more intensive therapy with the idea that if we're not going to be able to manage this long term, can we get rid of it to keep this person safe? So we try to cure those forms of the disease. Most often this uses combinations of chemotherapy drugs, fairly intensive chemotherapy. Sometimes we add or give interferon or antivirals either first or in addition to chemotherapy. People in studies, and then more commonly in Japan, have used this mogamulizumab, which is this monoclonal antibody that targets a protein, CCR4, on most of the cancer cells. And there's some studies underway for that. Even when we get this disease better with chemotherapy, it most often comes back, or almost always comes back. So we strongly consider things that we call consolidation. The term consolidation means to consolidate the remission, or really to make the remission permanent or forever. And that we think about for this disease, bone marrow transplant or stem cell transplant from another person. And that's called an allogeneic stem cell transplant. And more data as we have over time gives us the experience that when people get into remission, following that remission up with a stem cell transplant really gives the best chance that we cure this disease, as it almost always comes back if we're not able to do that. And there's a number of investigational treatments, some early medicines in development or in study that preliminarily have shown good activity in this disease. And we may be seeing those incorporated into some of these treatment paradigms, either alone or in combination, hopefully in the near future. Some colleagues of ours working at Imperial College in London, Aileen Rowan, Lucy Cook, Graham Taylor, they have a really unique clinic there. So in the UK, if you donate blood and you're identified as having HTLV1, one that removes you from the blood donor pool. But if you're diagnosed with HTLV1 as just a carrier, they put you in touch with this clinic, and this group runs a clinic for carriers of people with HTLV1. So you get referred, you can go or not go. If you go, they look at your blood, they look at your general health, they give some instruction about not transmitting the virus, and they really try to understand how to take care of people with this. And one of the things that have come up through their studying is that what you can see in the people who eventually develop lymphoma, or there are this series of mutations that they can identify often in the cells that predict over time maybe who's more likely to develop cancer and who's less likely to develop cancer and remain an asymptomatic carrier for years or for their life. And some of these are just technical things. These are different mutations they've detected. But I think the points that I'd make on this slide is one, even a year or two before diagnosis of cancer, if you look at the sort of the colored bar here, that's the number of mutations. You see that there's an increase in the number of mutations and maybe some specific mutations. And the other thing is that very early on, people start to express this marker called CCR4 on the cells that might down the road become cancer cells. So the drug mogamulizumab, which targets CCR4, can potentially target those cells. So there's some studies with us underway or about to start soon, where we're looking at are there strategies, working with a group in London, to try to identify people who have the virus, who are at risk of developing cancer, and could we do an early intervention? Is there a way to target some of these potentially bad cells? and try to take them out of circulation, hopefully well in advance of cancer ever developing. That's a clinical trial. We don't know yet whether that works. We don't know whether it's safe, but it's an idea, and at least the work that the group at Imperial College has done has really set the stage that if we can identify people with this difficult disease before they have cancer, it gives you opportunity to try to intervene and sort of change what's going to happen. I'm gonna skip that because I think that was out of order. So I think the next thing I was going to talk about was enteropathy-associated T-cell lymphoma and monomorphic epitheliotropic T-cell lymphoma. Sorry, give me one sec. These are two diseases. They're what we would typically call aggressive or often fast-growing T-cell lymphomas that develop in the lining of the gastrointestinal tract. And where these develop, if you just see, this is just a picture of a histology slide of a biopsy of the intestinal tract. So this is sort of what we call the lumen, or the if this is your intestinal tract, there's the lining or the lumen, where the GI tract works. And this is characteristic. And these lymphomas develop sort of right along the surface and in the subsurface layer of this, and that's their primary home. They're not from lymph nodes. They usually develop from T cells that are resident in this area. This is just a picture of a PET scan showing the dark is where there's PET uptake, and this person has lymphoma throughout their gastrointestinal tract and really has it nowhere else in the body. And these lymphomas are often just confined to the gastrointestinal tract. We used to have what we called enteropathy-associated T-cell lymphoma type 1, which was associated with enteropathy, which really means celiac disease. So celiac disease is an inherited disease where people have insensitivity to gluten. It's a little different than just gluten insensitivity in terms of how you feel. It's an actual diagnosis where you have almost an allergy or reaction to that. And in people with celiac disease, particularly if it's poorly controlled, there's a small risk of developing this aggressive lymphoma, and we would call that EDL, again, or enteropathy-associated T-cell lymphoma. And that used to be called type 1, and then there was something called EDL type 2, which was not associated with enteropathy. So that got a new name, and that name is now, we sort of colloquially refer to it as MEDL, but it's monomorphic epitheliotropic intestinal T-cell lymphoma. So a lot to say, mostly a descriptive term, but then we call that MEDL. At least in the US and Western Europe, EATL or EDL is more common than MEDL, M-E-I-T-L. Most people this is a very rare disease, most people would have enteropathy associated. Again, 1% to 2% of people with celiac disease may develop a lymphoma, so 98, 99% of people never do. And there is some genetic predisposition, and that is associated with genes that we see most frequently in Northern Europe, Western Europe, and consequently the United States, where monomorphic epitheliotropic T-cell lymphoma is more common in Asia. Not that much difference from the patient side in terms of how it presents, though for enteropathy associated, it's most often in the small intestine, and it can be similar for type 2 or for MEDL, but that may also involve the large intestine, where true enteropathy associated T-cell lymphoma usually does not. I think when people have this, there's a couple of issues both on the aggressive side and the non-aggressive side. So there are some slow-growing or indolent lymphoproliferations of the gastrointestinal tract that are either slow-growing lymphomas, or sometimes we'll use the word lymphoproliferation to describe a process that's not really a lymphoma, but it might mimic a lymphoma or be extra lymphocytes, but we don't think they're truly malignant or have truly malignant behavior. Some of those distinctions are a bit semantic, but they are things that we talk about when we're thinking about classifications, what we call lymphoma and what we think may be a short of a cancer, and we call that an LPD or a lymphoproliferative disorder. So there are some more indolent or slow-growing or non-dangerous lymphoproliferations that can present in the gastrointestinal tract. So if this is found incidentally, or it's found in someone who feels well or who's had it for a long time, again, we would want expert pathology review and make sure that it really is one of these aggressive lymphomas that need treatment, because they do need aggressive treatment versus something that could be watched or treated more mildly. And then on the other side of that, there's a group of people who present with perforation or obstruction. So the first sign that they have this is that their bowel is obstructed or could have got blocked and actually got a hole in the bowel, and that can leak bowel contents into the abdomen. People can get quite sick or septic. So there are a handful of people who are so sick at presentation that they're really too sick to get what we think are optimal treatments, which tend to be aggressive chemotherapy. They might need surgery initially. They might need a period of recovery, and that can be sometimes quite challenging if you also have an aggressive lymphoma. What we know is that if people use CHOP-based therapy or combination chemotherapy, a small number of people are cured, but we move that number up quite a bit, we think, if we give more intensive chemotherapy, adding more drugs or different regimens to CHOP, often considering consolidation with what we call high-dose chemotherapy and stem cell transplantation. Sometimes for this disease, those would be using a person's own stem cells. Sometimes they would be using another person's stem cells. But those sort of very intensive chemotherapy approaches really give the best chance that people are cured, and this is not a disease where we're often able to manage it just for many years with mild therapies. I'll next talk about hepatosplenic T-cell lymphoma. So hepatosplenic T-cell lymphoma is another one of these ultra-rare diseases. It usually shows up in young men, maybe late teens, 20s. And it's often associated with some underlying immunosuppression. So either someone has an underlying immunosuppressive disorder from an illness, or sometimes people have an illness that requires immunosuppressive therapy. And the closest link we've seen is for people who have inflammatory bowel disease. So those are things like Crohn's disease or ulcerative colitis, who need to be on strong or chronic immunosuppressive therapy, including some of these drugs that are anti-TNF drugs. Things, the brand names are things like Enbrel or Remicade. Sometimes, like when you see on TV, they'll advertise a drug, and then in the quick spot, this drug may be associated blah 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 lymphoma, development of lymphoma. Often those are immunosuppressive therapies that have risks of lymphoma like this. Those risks are very low, but not zero. So it is something that I think when people are on these therapies are often talked about. This tends to be one of the most aggressive lymphomas when people really have it. It often grows very fast. People can get quite ill, and it can be challenging to diagnose. So most often people do not get swollen lymph nodes. They almost always have spleen or bone marrow disease. It's called hepatosplenic, and usually have liver involvement, but not lymph nodes. And sometimes diagnosing these from a bone marrow or a liver biopsy can be challenging. Certain characteristics give the doctor or the pathologist a clue, but again, recommend that this is done at expert centers. And T-cell lymphomas in general, but this one in particular is associated with something called HLH or hematophagocytic syndrome. This is sort of what we call like a cytokine sort of catastrophe. These tumor cells can be very active like other immune cells, causing things like fevers or inflammation. And sometimes that inflammation can get so extreme that someone's immune system is actually ingesting or consuming some of their own blood cells. So they get low normal blood cells because the lymphoma is either doing it itself or stimulating other cells to sort of ingest and destroy normal cells. So people can have bleeding, they can have infections and be quite sick. And usually that's something that needs to be recognized often within days or a week or so to fix, or can be life-threatening. This gets a little bit technical, and I probably was debating whether or not to show this, but I'll try. So when we talk about gamma delta T-cell lymphomas, just here, I just wanted to make the point that when you have normal T cells in your body, as they go through maturation, they develop different rearrangements, and then they express a T cell receptor on their surface. So that's like shown here. This would be a receptor on the surface. That T cell receptor, if you can see my hand, would sort of bind to something, whether that's COVID-19 or a different infection or a different cell feature. And then that T cell lymphoma has that specific job in the immune system. And that process of rearrangement, people either have a T cell receptor on their surface that's a gamma delta or an alpha beta. Most of your normal T cells in your body have an alpha and a beta receptor. A subset of your T cells in your body have a gamma and a delta receptor. And the gamma delta T cells just have a different job in the normal immune system. So these are the normal T cells. If you were in person, I could see your faces. I could tell you if I was losing you, and I should just move on, but I will persevere. So the idea is when you get a cancer of T cells, basically what happens, is a normal T cell has become changed in a way that cell is growing abnormally, dividing too much, not dying. So you're accumulating this population of abnormal and cancerous T cells. So some of those will be gamma delta T cells, some of those will be alpha beta T cells. There's a couple of very aggressive diseases like hepatosplenic T cell lymphoma that are from gamma delta T cells, or usually from gamma delta T cells, and gamma delta is part of the name. But in other T cell lymphomas, they may have a gamma delta T cell receptor, and that doesn't necessarily make it a gamma delta lymphoma. I'll find out at the end if there's questions on this. So when someone's diagnosed with a gamma delta lymphoma, it's not always like hepatosplenic gamma delta T cell lymphoma. And we do from time to time see people based on this gamma delta expression told that they have or they think they might have one of these very aggressive gamma delta lymphomas. And that needs to be sorted out, because if you have that, you really need this aggressive therapy to try to cure you, because these can be very dangerous diseases. But if you don't have that, you may not need that therapy. And this can be tricky to sort out. So there's a group of slow-growing leukemias called LGL, or large granular lymphocytic leukemia, that often don't need treatment, that can have a gamma delta expression, and it's important would be to sort that out. There's some reactive processes or non-cancerous processes that can have a gamma delta expression, and then other T-cell lymphomas may have gamma delta expression. So that was just a word about the importance of really clarifying and trying to understand the diagnosis as best you can. This is a disease that we really need to cure to keep people well, and we really tend to use very intensive short course chemotherapy and try to move people quickly to allogeneic bone marrow transplantation. So a bone marrow stem cell transplant from another person, and that really gives the best results that this can be gone forever, but it's often a disease where you have to move fairly quickly and use that intensive therapy. Subcutaneous panniculitis like T-cell lymphoma, which wasn't technically on the topic, but I thought I'd mention. So subcutaneous panniculitis like T-cell lymphoma. Subcutaneous means under the skin. Panniculitis, panicula is sort of the fat of the skin, and people can get inflammation of the fat. And occasionally that can be from a lymphoma. So this is a skin biopsy. If you think it's a punch biopsy going down from the skin, so this is the surface or the epidermis of the skin, and then you have what's called the dermal layer. That's the second layer of the skin, and deep to that is the fat under the skin. Everyone has fat under the skin. Doesn't mean you're fat. Everyone has fat under their skin. And what we see is that we see an infiltration of these T cells in a very certain way, where they kind of ring, or sometimes called rim, the fat globules. And this has a very specific appearance under the microscope, or a fairly specific appearance under the microscope. And in the person, often you have like these little, either they're areas of swelling or firmness, or sometimes it's almost like what we call lipoatrophy or lipodystrophy. So the fat almost melts away a little bit, and you have these little dents in the skin. And these are things that often you can feel more than you can see. And I think this PET scan just showed that nicely. So this is a PET scan looking at a cross section. This is the heart, this is the lung. So again, we're not in person, we're looking at a cross section looking up from someone's feet. And if you just see the skin here, and you can see how the PET scan really shows up where the lymphoma is just under the layer of skin. So it's important for this that you try to get the right diagnosis. There's an overlap with other kinds of panniculitis or panniculitides. So sometimes through infection or inflammation. There's an autoimmune disease called lupus, which can sometimes cause a panniculitis, and it can be very tricky, again, to sort out what's really in the lymphoma family and what's really inflammatory process or reactive process, or lymphocytes but not cancerous lymphocytes. For most people, as we have more experience, this has an indolent course, and that we can manage it long-term with mild therapies. The lesions may come and go. Rarely do they progress outside the subcutaneous fat, so we don't typically see it in lymph nodes or other organs. We're learning that for many people, we can manage this okay with mild chemotherapies like methotrexate, so a very low dose of a pill chemotherapy that's quite safe. There's a drug called cyclosporin, which is really more of an immune suppressant that can sometimes do it, and these are oral drugs, and you can manage it mildly as the disease is not usually dangerous. There are occasional patients where the disease behaves in a more aggressive way. Sometimes it can cause that HLH, all that inflammation that destroys the normal cells that I mentioned. And there are people who really need real chemotherapy or combination chemotherapy for this. And those people, if they get that, they're usually okay. But sometimes it can be tricky to decide when mild therapy is adequate and when you might need to escalate to more intensive therapy. So again, seen at a center with pathologists and doctors who have some experience with this. Here I point out that if this has a gamma delta expression, again, this gets a little technical, we don't call it subcutaneous panniculitis like T-cell lymphoma. So this is one of those areas where if the T-cell was a gamma delta T-cell, not an alpha beta T-cell, then we would give it a different name. Then I was just going to talk about NK T-cell lymphoma. So NK T-cell lymphoma is another virally driven lymphoma. It's driven by the Epstein-Barr virus. So as you know, or you may know, Epstein-Barr virus, most of us have been exposed to it. It's a virus that causes mono. Most people get it as a child, and a little bit of virus lives in your body, often in the nasopharynx or the lining of the nose or the mouth. and really just usually sits tight. Occasionally it can reactivate and cause problems with viral reactivation, and occasionally, more common in Asia than North America, it can turn some cells into cancer cells. Usually when people get that, it shows up as like a sore on the top of the mouth or in the nose. Sometimes can be mistaken for sinusitis or coexist with the sinusitis. It can be hard to treat. Here's just a PET scan showing the brain has normal uptake, just the uptake in the area in the nose, because this really starts there. Less often it can show in other parts of the body, sometimes the oropharynx or the throat, and then rarely we'll see it like in the skin. It can show up in the testes or in the gastrointestinal tract, but mostly it's in the nasopharynx. This can be an aggressive disease, so we try to treat it usually with cure. And from historical data, people that have limited disease in the nose or the nasopharynx can sometimes be cured with radiation alone, because we now have effective chemotherapies, and we've learned that certain drugs, not typically the drugs in CHOP, but other drugs like asparaginase and other chemotherapy drugs are very active. Most people in the US with this will get some combination of chemotherapy and radiation therapy, again, with the intent of curing it. And this is a disease where there's been some advances in immune therapy. So as you know, in other lymphomas, less so in T-cell lymphomas and other cancers, we have immune therapies that work quite well. And there's a group of diseases that are called T-cell checkpoint inhibitors. These are drugs like pembrolizumab or nivolumab. They're used routinely for lung cancer, melanoma, and they've been a little tricky in T-cell lymphomas. Because they stimulate good T cells to fight cancer, there's been some cases where in T-cell lymphomas, they've actually stimulated the lymphoma to grow more quickly. But at least in this nasal NK T-cell lymphoma, these drugs look quite active and are often used now if initial treatments don't work, and are being studied as part of upfront regimens to see if we can both increase the cure rates and reduce some of the toxicity of what was otherwise fairly intensive chemotherapy approaches. So I think to sum up, and then happy to take questions, for the rare T and NK lymphomas, each is really unique. As we learn more about these diseases and get more experience, we're often developing subtype specific approaches really just for that disease or just that group of diseases. To really have a best chance of making best decisions, you need the right or the best, most accurate diagnosis. So for these very or ultra rare diseases, I think that really means expert pathology review, pathologists with experience, and often I should add probably adequate biopsy samples to really do the workup to characterize these as best as possible. We really recommend expert opinions for these because they're so rare. No one has tons of experience, so we share a lot of our experiences. But I think people who have some experiences treating these diseases can often make good recommendations or guidance, even if a lot of the therapies can be given, sort of in any office. And then a lot of what we do is collaborate in sort of learning about T-cell lymphomas in general, or these rare diseases, just so we can all learn more quickly by sharing our knowledge and experience. Ongoing efforts to understand the biology. There are big efforts to really understand these rare diseases, and a lot of those, which I decided not to go into today, are looking at therapeutic targets. So abnormalities within the cancer cells that give us targets for new treatments to study or to try. And there's some early clues that there may be some better ways of going at these diseases. So that's all I have. I will stop sharing. I really thank you for your time and participation. I'm really happy to answer any questions or expand on any topics if people want.
Thank you so much for that great presentation. One question I received beforehand was, how does one go about finding an expert in T cells? I think that's something we do see often on our helpline as well.
Yeah, well, we're here, and there's getting to be more of us. So, I think initially, where this wasn't well studied, more when I was starting out. I came to Sloan Kettering in 2001, and just doing T-cell lymphoma primarily wasn't really a thing. But I think as we've had more treatments and more understanding and more diagnosis, there really are. So I would say most of the major cancer centers, or I chair a committee called on the NCCN, which is the National Comprehensive Cancer Center Network, and we write guidelines, sort of educational recommendations for different diseases. So all the major cancer centers have a representative on that committee. So at most cancer centers, there's a person who that's part of what they do. It may not be only what they do. That's probably really only at the very big centers. But most cancer centers or university hospitals has someone who T-cell lymphomas is part of what they do. So I think that's often a really good start. I think through the LRF or through their network, and in days of telemedicine, it's often possible to see someone nationally, even just for an opinion, without always having to travel. some of that restriction on telemedicine is getting a little more restrictive since COVID's kind of a little less than it was during the pandemic. But I think it is a situation where sometimes it's worth a second opinion, both pathology review and a consultation. I think those are probably the best places to start. I don't know if you have other recommendations or resources, but that's probably where I would start.
And I'll add that LRF has a pretty robust offerings when it comes to understanding telehealth, telemedicine. We know that's kind of new. So I encourage anyone to reach out to our helpline after this program or after the Ed Forum for any of those additional questions. And another question I received.
Oh, I was just going to add though, and there is like a community of this, like for these rare diseases. So I don't know if this makes you feel better or not, but we do routinely get emails to like small groups of people where doctors ask questions. I have this, you see this, do this. So the community, at least with T-cell lymphomas, is fairly close and friendly. And there is a lot of sort of behind the scenes or in front of the scenes collaboration in really understanding some of these very rare or challenging situations.
And LRF also has a one-to-one peer support program. Again, I encourage you to reach out to anyone to our helpline for more information on that and to match with a patient with a similar experience. And one other question I received was finding clinical trials for these rare T cells. Is that something that is how would one go about that?
Yeah. So for those of us who have really studied this, we have a lot of clinical trials because we're really looking for new therapies. So if you look at websites for the bigger cancer centers, they would almost all have studies for T-cell lymphoma. So I don't want to advertise, but like our center, MD Anderson, any big comprehensive cancer center is likely to have it. And those of us who have sort of programs in T-cell lymphoma often have multiple studies. NCI.gov, like the clinical trials network, I think is helpful, though it is a very long list and it's sometimes hard to filter through. But I think that's another good place to look. LRF do you maintain a list?
We have our helpline team can definitely help anyone navigate clinical trials, recognizing that first-time users to clinicaltrials.gov, having that a little extra help from our helpline team can be really beneficial.
Yeah, sometimes you do a search on clinicaltrials.gov and you get like 1,500 hits, and it's a little hard to filter through. So I think those are good. Or because it's so heterogeneous, some trials have different eligibility. I think like reaching out, asking your doctor, or specifically asking your oncologist, or if you have a local cancer center, what they have available or what they know about nationally is good. I guess the other thing is, if you're really looking, is sometimes you can look at meeting reports and see, what medicines are being reported as showing early activity. And then usually the companies that have those medicines maintain on their websites the sites of their trials where those drugs are being studied. I think that's probably another resource.
Thank you. I don't see any other questions. So thank you again for your excellent presentation. Again, this will be on our platform for the coming month. And thank you for your time today. And this concludes our Saturday session. So thank you again.
Thank you. Take care.